Welcome, everyone. Thank you for joining our session today. We're very excited to be joined with Susie Sietmann from GSK. I would like to welcome Susie Sietmann, Patient Engagement Liaison in Women's Cancers and Multiple Myeloma at GSK Oncology. Susie earned her BSN from Marquette University in 1996. She is both an oncology certified nurse through the Oncology Nursing Society, as well as an oncology nurse navigator certified generalist through the Academy of Oncology Nurse Navigators. She also serves on the board of directors for WOCA. Thank you, Susie. And on their fundraising committee. Susie's oncology nursing experience spans over 25 years. She began her career at St. Luke's Medical Center in Milwaukee, Wisconsin as an inpatient oncology and BMT nurse for 3 years, followed by a year of travel nursing. She spent 7 years as an outpatient RN manager and medical oncology with Oncology Alliance, and then returned to Aurora Cancer Center at St. Luke's, serving as an outpatient cancer care coordinator and gynecologic oncology for over 8 years. She continued to support the gynec department there for over 4 years as a cancer care navigator, helping new patients through all stages of their cancer journey. So please help me welcome Susie Sietmann, and I will hand it over to you, Susie.
Awesome. Thank you, Ashley. And thank you to everyone that's joining today. I'll be honest, I'm from Wisconsin. I just live outside of Milwaukee with my husband and 2 daughters, but today I'm traveling. So I'm phoning in from Kansas City. So hopefully we can make this interesting for you. And as Ashley said, maybe answer some questions for you at the end of our program. And I guess I don't get the fun of sharing my story. Ashley did a great job of telling you my history, but just loved being an oncology nurse, and now in my new role, providing education as a patient engagement liaison in the community throughout the nation. So kind of taking it to a new level and a level of travel again. So some things always come full circle, right? So it's fun to be here today. Again, here's an old photo of me, you know, a little touch up there, family photo from 10 years ago. Bear with me, I've got to get that updated one of these days. But I'm a part of the patient experience and advocacy team at GSK, and we work with advocacy groups throughout the nation, specifically related to women's cancers. And our role is to help patients feel knowledgeable, bold, and confident in their journey as they face their disease, whether it's ovarian or endometrial cancer. And I also support patients with multiple myeloma and myelofibrosis. So it's an exciting career, fun to be here. And I'm just so happy to be able to share some of the knowledge that I have from over the years. So what I'm presenting today is consistent with FDA guidelines, and I'm presenting on behalf of GSK. So we all know why we're here today, to learn a little bit more about this thing called maintenance therapy. GSK joined forces with the NOCC, or National Ovarian Cancer Coalition, and OCRA, Ovarian Cancer Research Association, and they developed a program called Our Way Forward, where they interviewed over 250 GYN patients as well as providers, and they put together some supportive materials, and you can go to our website, ourwayforward.com, and see vignettes from other women going through their cancer journey. They also gave information about what the patient thought was happening during their visit with the provider versus what the provider might think he or she is delivering to the patient. So it was a nice study, and we were able to pull a few elements away, and we're just here to kind of help fill that gap. So as you can see from the numbers here, 49% of women feel that they are unsure of the path forward after they're initially diagnosed. It's a very challenging time as a nurse navigator. I found that, you know, it wasn't just the woman in the bed, it was often the family, the care partner, the spouse, the daughter, someone in the room was helping hold the torch, if you will, on the beginning of that patient's journey. So I always knew it was important to not just tell the patient, but also to tell the ones that were supporting the woman going through her new challenge that she did not sign up for, right? And then 47% of patients felt that they didn't know what to expect after treatment. So I knew just from my own memory, right, that I needed to hear things more than once to retain it. So I, took that into practice with my patients. So I would tell you what is going to happen. I'd retell you. And then when you came to the clinic, I'd tell you again. So I'd always, reinforce that no question is a dumb question, and just made people feel that they could trust me and turn to me and pick up that phone when they just couldn't remember where they were going the next day, right? And then last but not least, 71% felt that they felt very anxious before their visits to a healthcare professional. So, with the emergence of electronic charts, right, and living through COVID, we all know we have new ways of connecting with our provider. And sometimes that helps you be able to put your head on the pillow at night. If you can just message your provider non-urgently and just know that the question's now out there, I've put it in the parking lot, and I can wait for the answer, right? So I do think that number is probably coming down, I hope, but it is still a very anxiety provoking experience to go through advanced ovarian cancer. So today we're going to talk a little bit about, what happens after that initial treatment. I'm not sure who's all in the audience today and where you are on your journey, but I'm going to speak broadly to that topic. I'm also going to address maintenance therapy to help you understand that language. It's not a common language. Not every physician necessarily uses that word for that type of therapy after first-line chemotherapy, also known as frontline treatment. And then we're going to talk a little bit more about communication with your provider, right? So I kind of alluded to that a little bit through the Our Way Forward campaign and some of the things we learned to help give you tools to advocate for yourself, because we know more and more as patients, we need to show up and ask those tough questions. And last but not least, I'll give you a few care tips and some resources in the community, both locally and nationally, that you can turn to for further support. So we'll start from the beginning. What happens after that initial treatment for advanced ovarian cancer? I'm going to back it up a hair, right? So typically a woman that has been diagnosed has these initial symptoms, and we all know they are vague. You may have gone to your PCP, a urologist, a GI doctor, right? Many people feel dismissed. The pelvis and the pelvic organs are so low, right? So someone does an abdominal ultrasound, but they don't do a pelvic ultrasound. So we've heard that story one too many times, right? The other problem is that our ovaries are so small as women, especially after giving birth and after menopause, that they need to get pretty big to give us symptoms, right? So again, a disadvantage for early diagnosis. But once we are suspicious and we see a mass, we can often then order a blood test called a CA-125. We need to prove that we saw that on imaging, whether it's CT or maybe even the physician palpated it during a pelvic exam, right? But some sort of documentation that there's a pelvic mass, and we can order that blood test. Not everyone has that blood test before the next step, which often is surgery. For some women, they make the decision with their provider that perhaps let's do a little bit of platinum-based chemotherapy to bring the tumor burden down. So it's, not one-stop shopping, if you will, when you get to this early stage, right? Not everyone goes straight to surgery, and the recommendations change. If you look back in time, there was a time when women would just have open abdominal surgeries. That was the best route, the first route. then we went into, let's do a little adjuvant or neoadjuvant chemotherapy, which is what they call it. And then it varies by provider, right? What do they believe? So it's a hard place to be a patient with all these variables and changes in treatment guidelines, right? So we're here as nurses and nurse practitioners to kind of help fill that gap, help you feel educated. So again, after that initial surgery, most patients with advanced disease will receive a platinum-based chemotherapy. And what's that? Two drugs out there, carboplatin or cisplatin. Okay, so it's the word platinum that you want to focus on. I would say 85 to 90% of folks are going to be getting carboplatin. Cisplatin can be a little harder on the kidneys. And the good news is that with that, many or most, 8 out of 10, are going to achieve a remission, and a remission is no sign of disease. And how do we determine that? Usually with imaging, how you feel, right? That sometimes is the first question. If you stay very symptomatic during chemotherapy, we might stop after 3 cycles and say, let's take another look. Let's do some imaging and see if maybe you're resistant to what we're trying here. And the good news is most of the time we are seeing a response. So from there, the patient goes on in that period of remission. And, historically, we'll say 5 years ago or more, we would say, well, this is, go take a vacation, or let's just keep an eye on you, come back every 2 or 3 months. We'll do a pelvic exam, right? So we would call that watchful waiting. Unfortunately, with ovarian cancer, it can be a chronic, long-term cancer diagnosis, and most women with that advanced diagnosis initially of stage 3 or 4 will relapse. And when I say most, the number is as low as 60%, and we hope, right, with new treatments and with an addition of maintenance therapy, we can keep it closer to 60%, but it does go as high as 85%. It depends on the volume of residual disease after surgery that we determine what your risk is as well. So I would always tell patients, you know what, we are learning, and you'll be learning more about your cancer every time you see us and throughout this first year. So we learn a lot initially. How did you present? How involved did things look? How high was your CA-125? Then you have the surgery, and then we come back into the room and we might say, we got everything down to 1 centimeter or less of disease. Or we might say, you had 0% residual disease. We got everything that we thought we could get. And it's tricky. It's not just one ball that we're removing. The surgeon is removing ovarian cancer, and ovarian cancer tends to splatter. We used to say sometimes it's like when you're putting weed killer down, right? You're spreading it all around because you want to keep it away. It's opposite here with ovarian cancer. It splatters within that peritoneal cavity. So it's often not just contained to the ovaries. And then the physician does his best or her best effort to remove it down to less than 1 centimeter. So again, also the size of the lesion after surgery can determine someone's prognosis, right? Other things that determine prognosis is that initial response to first-line therapy. With that chemotherapy, as we discussed, typically it's 6 cycles of carboplatin and Taxol. Some people will get 8, some people get 9. It kind of just depends on your surgeon and what he or she is seeing as far as a response throughout those cycles of chemotherapy. And now we're back to our options, okay? Active surveillance or maintenance. And that's what I'm here today to talk to you about. Active surveillance, again, is keeping that close eye on you, and maintenance therapy is a treatment time. It's a treatment option, and it's given to delay progression of disease or keep you in a remission, right? This is your first remission. And if we can keep you in that remission long-term, that is our goal. So let's talk a little bit more about maintenance therapy as an option. Like I said, not every physician is going to refer to it as this. He or she may say, I'm going to continue something we're already doing in your first line therapy that I think is working. So what might that be, right? It might be a VEGF inhibitor like Avastin. So some people will get that in addition to their carbo and Taxol frontline. And again, it's a case by case decision if someone is going to get 2 drugs or 3 initially. If the physician says, you know what, it did a good job, you're tolerating it, let's keep that one going. So that's continuation maintenance, right? Another option would be for the woman that maybe didn't have Avastin, and we wanted to give you a little added protection. We wanted to shoot for 6 months of remission, okay? So the goal is to make carboplatin your friend, or the drug that we can keep in the back pocket, and if the cancer comes back, we can offer it to you again. The only way we can offer it to you again is if you go into 6 months without a recurrence after that first line therapy. So why that is the main reason that we're giving maintenance therapy. We want to keep you platinum sensitive. So we might switch it to a new drug in the form of a PARP inhibitor, or some may start Avastin for the first time in that period of a new drug if they never saw it before. And again, it's case by case. All of these maintenance drugs come with their own side effect profile. So it's a decision that you often make with your provider. Now in the 50s, and that's when my mom was offered her first her hysterectomy, the decision always wasn't a mutual decision with your doctor, right? Things have changed quite a bit where it's a discussion. You get to hear the pros and cons, right? But it's also a burden. All of a sudden now you have to try to understand something that, a new language you've never heard before. So it's a tough place for an ovarian cancer patient to be. So moving on, it's not a new concept. So Ashley shared that I was a bone marrow transplant nurse at St. Luke's the first 3 years as a new nurse. And often we would give them their induction therapy, and then we would give them more treatment in the form of maintenance, because it was the same concept. We wanted to keep that momentum going. Why do we change it? We change it because maybe that induction or that first line treatment has toxicities, and we know your body can only tolerate so much at one time. So we don't want to always stay with that aggressive one. We want to use it up front, get the bang from the buck from using it up front, and then give you something to keep the momentum going. So here's other disease states where maintenance therapy are used: in solid tumors, in other blood tumors, in breast cancer. You hear the commercials about hormonal therapies for breast cancer. They refer to them as aromatase inhibitors, estrogen receptor blockers, targeted therapies. You may have heard of a drug called Herceptin that's been around for many, many, many years. So that is a form of maintenance. In multiple myeloma, they also have something called targeted therapies. So that's where we give an immunomodulatory drug or a proteasome inhibitor, right? Crazy names and words that you don't need to know, but it's just an example that you are not alone as an ovarian cancer patient, that you may be offered maintenance therapy. So again, who is eligible? Not everyone is eligible for maintenance therapy, but I will kind of explain this diagram of the 2 scenarios where your physician may offer it to you. So you're newly diagnosed, right? As I've been explaining, you got that frontline therapy with a platinum-based chemo, so the carbo or the cisplatin, and you had a partial or a complete response. And how do we know that if you had a partial response? If you had a 30% reduction in the total sum of the lesions that were seen on imaging at diagnosis, you got that frontline treatment. If we saw 30% reduction, we could say you had a partial response, or you had a complete response, right? So most of the disease or all of the disease that is gone on imaging. So that would be a scenario where we could offer you maintenance therapy. Recurrence is the second scenario. So this is a woman who maybe didn't get maintenance therapy. She was in remission for 6 months or more and recurred. So she's platinum sensitive. Okay, so she had that subsequent treatment, and it's with a platinum-based chemo. She had to have a platinum, and then also went into that partial or complete response again for at least 6 months. Those are the two scenarios where you would be offered maintenance therapy. So ASCO, or the American Society of Clinical Oncology, recommends maintenance therapy for women who are eligible, but many women choose watchful waiting. So you might ask, why would someone do that? So there's many reasons. Again, this is a individual decision that you make with your provider, and I'll give you some explanations of that. So the proportion of women who receive maintenance therapy is not very high at the time of the production of this program. I think this was data from 2022, May of 2022, a year ago. 55%, so more than half of women after frontline treatment chose, or the decision was made for them or made with their doctor, to do active surveillance, versus 45% who did go on maintenance in the form of a PARP inhibitor or a VEGF inhibitor. For the setting of recurrence that I explained in the previous slide, 44% of women chose active surveillance, and 56% chose to be a little more aggressive and say, let me give this maintenance therapy a try, right? So Lynn is a cancer patient. She's one of the 250 that we interviewed, who say that, just reminding us all that many people go through remission, have recurrences. And it's our job to keep you in a period of quality of life for as long as possible, help you continue to reach your goals. And we never know, right? We're always getting new drugs. So I would tell patients that your ovarian cancer is more like a chronic disease. I would sometimes compare it to diabetes, because we have so many options of different drugs that we can provide to you that may be the one that is smarter than your cancer, right? So always maintain that hope. Like I said, we are getting new data and new therapies all the time. Okay, so back to maintenance therapy. Again, it can extend progression-free survival, and I'll see if I can move this slide a little bit, before recurrence, right? So that's that first scenario of ladies that got it after their first line therapy. And they compared this against placebo, okay? And the data reflected that we were able to get them in a progression-free survival and delay recurrence after their first line therapy. So what were we able to do? We were able to keep them platinum sensitive. So they got their frontline treatment with their platinum chemo. And if they responded with that CR or PR that we talked about, complete or partial response, and got that maintenance therapy, again, we were able to keep them in a remission of 6 months or greater. For the ladies who perhaps didn't see a maintenance drug, and it's not a drug that we have data that supports using it more than once. So you're either offered it after frontline or you're offered it after recurrence. So now we're kind of moving on to the woman who stayed in remission without maintenance therapy, but recurred. And now she still has an opportunity to get maintenance therapy. And again, she still needed to have gotten a platinum drug. And why did she get a platinum drug as a second line therapy? Because she was platinum sensitive, right? So that's that kind of that golden ticket that if we can keep you platinum sensitive, we'll be able to use one of our best tools of ammunition, if you will, upfront, early, and often. Every time you recur, our goal is to use it if it's still kept you platinum sensitive. So I recall a patient of mine, I think she was in year 7, and we were still able to pull carboplatinum out of our back pocket, and often it's just given single agent then in that scenario, so not with the Taxol, right? And sometimes we were able to dose reduce it, so we would keep her quality of life higher, so the toxicity level down. So that's the beauty of it, right? If there's any beauty that can come from chemotherapy, is knowing that we can still use it, right? So again, this is just a visual of what platinum sensitivity means or looks like on a calendar. It's greater than or equal to 6 months, okay? And platinum resistance is where your cancer comes back in less than 6 months from the time you got your platinum-based chemotherapy. So we're going to go to the next slide and talk a little bit about this class of drugs called Maintenace and the safety of these drugs, right? So typically they have minimal side effect profiles, even though you see all these words on the screen, but are much more tolerable than the IV chemotherapy. For the PARP inhibitors, some women, and there's more than one PARP, so one of the PARP inhibitors may have a greater side effect profile that might cause more nausea and vomiting. So you're talking to your doctor and he wants to put you on a PARP. He might say, Joan, you really had a lot of problems with nausea and vomiting with your carbotaxol. I might not give you PARP drug A, I'm going to give you PARP drug B, right? So I don't want you to experience that. I don't want you had a small bowel obstruction perhaps, right? He or she doesn't want you to experience that again. So this is how some of the decisions are made. Also hematological. So one of the PARPs has been known to cause your lab values to maybe drop initially. Okay, it's the weirdest thing. It's totally different than IV chemo. It happens once and it happens up front. So for that PARP, we'll call that PARP B, right? They might have low platelet count or thrombocytopenia in that first 7 to 10 days. So we give the provider guidelines to say, let's hold the drug a week and see if the platelet count recovers. If it recovers, then we can restart at that dose or a lower dose. Anemia can sometimes happen, and then neutropenia. But for the patients offered PARP B, right, typically this is something that resolves with it by the time we're on to the 2nd month, right? And it just becomes a distant memory, okay? This is a very rare side effect, but it can happen. It's a risk of myelodysplastic syndrome, which is a blood cancer, and it happens in, I want to say, an average of 1.5% between PARP A and B, okay? And then last but not least, it can cause a temporary increase in your creatinine level, which is a reflection of your kidney function. Again, this is temporary. It can happen in both PARP A or PARP B, okay? And it resolves when you stop taking the drug, but we just keep an eye on it. So these women would have monthly lab values where they're looking at, like they call it a BMP or CMP, where they're looking at the basic or the complete metabolic panel to keep an eye on that creatinine. The PARPs are oral, so that's another thing to take into consideration. A patient might say, you know what, I want to go on a cruise for 3 weeks. This might be the right drug for that patient. The second drug is the VEGF that we talked about, and that can cause some vascular problems. I had many patients on the VEGF, and oftentimes, even though it says hypertension or bleeding, we wouldn't see these side effects to maybe cycle 9, 10, and 11. And what I would tell women, because this can be very anxiety provoking, is you're not going to go from not having a bloody nose to having a gushing bloody nose. Typically these patients, it'll start out very mild with this little drop of blood when they wake up in the morning, and they dab it 3 times and it's gone. So it's a dialogue that we can start having with them and keep a closer eye on them. Maybe, if it keeps happening, reduce the dose a little bit, maybe reduce the frequency a little bit. So even though these side effects may look scary, venous thrombosis is a blood clot, right? A heart attack, again, hypertension. When you're going in for this IV class of drugs, you're getting it every 3 weeks. Those nurses are checking your blood pressure. And I'm telling you, if you're 150/90, the doctor's office is getting a call and they're making a determination if we need to start you maybe on an antihypertensive, and then we can keep you on the VEGF, right? Again, these patients aren't going into hypertension crisis and being sent to the ER. Patients who have been on Avastin or a VEGF for much longer do run the risk of gastrointestinal perforations in the form of a bowel perforation. So the bowel wall breaks open, okay? And last but not least would be maybe some wound healing issues. So some patients have a comorbidity maybe with their ovarian cancer, and we might choose not to put them on a VEGF inhibitor because they have an ulcer on their leg from their diabetes that isn't under control. So again, these are examples of how the doctors make these decisions with the patient. So there's more than one choice for maintenance treatment. It's essential to have those conversations with your healthcare provider about what is best for you. And this is from Karen, right? So hopefully you're all with a provider that you feel comfortable talking to, but if not, bring a loved one with you, someone that can help support you. So again, why a doctor might make some of the decisions he or she makes with you and why they might not put you on maintenance. Frankly, the stage of the cancer is a determining factor. So if you don't have advanced disease like stage 3 or 4, you might not be a candidate for maintenance therapy. It's not something you need, or is there an indication or approval for using it in earlier stage cancers? And again, case by case, we've already talked about scenarios where they look at the benefit risk assessment. And then again, for the patient, those conversations about side effects, right? Like, I don't want any more drugs that are going to give me that severe nausea, so we give you a good break and we're not going to give you PARP A that might cause more nausea. Treatment costs can come up initially. The doctor orders the drug. All of a sudden, we need to call the insurance company. And as you know, it may take 1 or 2 phone calls, maybe 3, before we find out that it's approved. So that can be anxiety provoking, right? And some patients say, well, I can't afford that. But if the nurse and the social worker do a little more work behind the scene, oftentimes the pharmaceutical companies will have programs that will help pay for the drug. So just my reminder to everyone is there are more and more oral drugs coming onto the market for oncology treatment in general. Is just hang in there and make sure you're finding out who the financial counselors are and the people that know the ins and outs of working with the companies that can provide extra financial coverage for some of these drugs. The opposite scenario, of course, which we've already talked about, is active surveillance or watchful waiting. Now, this can happen at any point in your journey, but when you are in surveillance, your visits to your healthcare provider typically look like this. So year 1 to 2, you're going in, typically it's every 3 months for 2 years. Years 3 through 5, it's every 6 months. And after year 5, it's annually. So I would often have patients, because my provider was in Metro Milwaukee, but they lived in a town 2 hours away. Sometimes I would set them up with an oncologist to give their chemo, but I would remind them, you still need us or a gynecologist to do that pelvic exam. And sometimes that can fall through the cracks. So if that scenario applies to you, make sure you're also either getting in with a GYN who knows the guidelines that you need that pelvic exam, because that's one of several ways that we can keep an eye on your disease and watch for recurrences, right? Also, those periodic blood tests for the CA-125, and that's that blood marker. If it's not elevated at diagnosis, sometimes it is then considered not a marker for you. It's not good or bad if it's not. It has its pluses and minuses. It can be very anxiety provoking to always be inquiring what my CA-125 is, but it can also be a tool. to the provider, to the patient, to kind of keep a gauge on where we are with your disease. HE4 is human epidermis protein. It was out on the market for 1 or 2 years. Some providers, I would say 5%, still check HE4s, but most do not use that as part of their monitoring. It just wasn't a great tool or lab value. And then last but not least, chest x-rays, chest CT, abdomen, pelvis. If abnormalities are detected, there's no schedule for that. We base it on symptoms. So we listen to you. That's why we're always asking how you're feeling and having you call us. So again, talking with your HCP. I know we're going a little bit long here, so I don't want to torture you here, but here's some questions, to consider having with your doctor, or even to ask yourself, right? Since my surgery, what has changed in my health or personal life? Maybe your philosophy has changed. Maybe what was important is not so important anymore. So, taking that into consideration when you're deciding if maintenance therapy is right for you. Okay. I'm learning a new disease, oncology disease this week in Kansas City. And that's one of the big topics, is how do people make decisions about whether they're going to do some of these treatments? And it may be family, it may be grandkids, it may be they just retired and they're like, this is not, I'm not going to accept this, right? I'm going to fight. So for everyone, it's a personal journey. How important is it for me to delay the disease progression, right? So we talked about the value of that maintenance therapy. It can give you more time before you recur, and it can also prevent you from recurring. And the third scenario is it can keep you platinum sensitive. So that's one of the bigger drivers is if we can keep you platinum sensitive. But obviously, if we can keep the disease from ever coming back, that's the ultimate goal. And then treatment delivery preferences. Again, one of 2 or 3 of the drugs, the PARPs, are orals, and the other one is an IV infusion every 3 weeks. And for some, there's value of coming into the clinic where they got their chemo and seeing their infusion nurses. There is emotional support that is gained there. So, but for others, transportation is an issue. Maybe they never learned to drive. Maybe they didn't need to, right? Or there's one car that they're sharing. So all of those are personal decisions. And then looking at the side effects of the drugs that the doctors are offering you. We talked about finances and insurance coverage. And then having a care partner. Do I have someone who can support me while I may now go on to a new set of side effects that I didn't have before, right? Because we're always learning how to best manage those. So this is a quote from an actual ovarian cancer patient named Nora. She says, "Gather the courage to take that initial step, because the only way you can go is forward." So, just kind of a nice quote to remember as you're going through this journey. As you're going in and out of those doctor visits, right? These are just good reminders. Prioritize your questions, make a list of questions. You might have 3 people come into the room, the MA, the nurse before the doctor or after the doctor. So sometimes you don't get all 5 of your questions answered directly by the doctor. Maybe you get your 2 main ones or your 3 main ones. And then you have that 4th one and you ask the nurse and she has the answer, or she can go back and get that answer for you because he's had to move to a new room or she's had to move on, right? Again, bringing family members, it's always good to have that second set of ears and what just happened in that room, what did we hear, maybe sit in the car for a little bit and write some of it down so you don't forget. Family always wants to know how the visit went. So our memories are not great, especially if you have something called chemo brain, right? Writing stuff down, and then maybe you didn't get it all down accurately with the doctor, but then you can ask the nurse, now, what did he or she say, right? Asking for them to print out your records, right? I mean, if you're old school like me, I still like stuff on paper. So say, I know I can go look in my chart, but could you print it for me? It'd be really helpful, right? And then, just letting your doctor know your personal preferences about communication. Some people don't want to know anything. Doctor has a look. What do we need to do? Let's move on, right? Everybody's different. So these are some ideas of questions to ask your physician. We're back here. We've just had another scan. What are my options and what should I consider? Genetic testing is very big now, and that can guide decisions around maintenance therapy. So should I consider this BRCA testing I've heard about? Should I do genetic counseling? I'm not here to give medical advice, but it's definitely a very good starting point. Okay. What symptoms would signal a recurrence? And when I first started working in oncology, I had an oncologist that had a very specific way of us getting the charts ready for a new patient. And he had a column about symptoms. And what I learned over time was the symptom that the patient had at diagnosis can often be the symptom that rears its little ugly head when someone is recurring. So, asking your doctor, he or she may be able to help you identify that too, if you don't know or don't remember. And then how can I manage my anxiety? There's so many resources out there. So much of it is web-based, which I do find a little alienating. 20 years ago, there were more support groups in the community, but you just have to keep looking, don't give up, keep talking to people you meet in the waiting room, in the infusion rooms. You will keep learning. I know I keep learning as an oncology nurse every day. So those are just some tips. Again, we talked about writing things down after the visit and then using these electronic systems to ask questions in between your visits. So last but not least, we have some care tips and resources. Feel free to do, screenshots if you haven't already been, for patients, talking regularly with their care team, letting them know about side effects. You may have a side effect and not know that there's a way to solve it, right? Sometimes we try to solve it on our own, but I'd have patients that would come in and 2 months had gone by and they tell me all this horrible stuff that happened. And I'd be like, why didn't you call me? Right? We have a way to fix that. So I had one that was specifically bad at letting us know, and she just suffered. But you can only help those that will help themselves, right? Again, good nutrition is always important in the form of fruits, vegetables, low-fat sources of protein, exercise for that anemia, that fatigue. I know I'm going to a conference on Thursday, and there's going to be a physiologist there, and he's specifically talking about fatigue and the value of motion. So we would tell patients, go to the mailbox, a day or two later, walk around the block, start doing some of that mall walking, whatever works for you. Lots of times when you're anemic, you lay down, you take a nap, you might wake up, you're still anemic, right? But there is data that supports activity in fighting that fatigue and that insomnia, right? And then for the care partners, that important person in the room, I would always take note of who is there at the first visit and get their name, make sure I had their phone number and permission to talk to them, because cancer care is hard enough. And I didn't like it if a loved one couldn't get answers from other people in the healthcare system because they weren't listed as someone we could talk to. So trying to take those barriers away was always important to me. So make sure your doctor knows, my sister, Becky, is okay to talk to, and here's her phone number. Please put it in my chart, right? Our nonprofit organizations like WOCA, right? People like Ashley and Jennifer are awesome. They have, if you're not on Facebook, I would recommend Facebook. They are constantly giving even me tips that I don't know about. So it's a great place and a wonderful group to be a part of. So this last weekend, we had the survivors brunch. and I met so many wonderful people. I don't know if there any of them were those of you that are in the audience today, but you know, it's one of my favorite events of the year. But we also have walks and races throughout the year too. Just kind of changes the whole experience for you, and it's a place to celebrate what you've been through, and you know where you've been and where you're going and the hope of the future, right? So take advantage of who we have locally and regionally. So all right, let's see if it's going to, it looks like I might be frozen. Oh, maybe not. You know, the internet, when you're across the country, let's see, I'll try and go slowly here. Oh, I know this is being recorded, so let's see, we'll go back one more. Advice for patients and care partners. We talked a lot about all of this already, so I'm not going to repeat it, but the main thing is writing stuff down. So data supports, in general, people who write down their goals are more likely to achieve them. So this is the message I want you to take away, because we need all the motivation we can get. And I know, as someone who's not dealing with cancer, I need that motivation. So there is value in writing things down, you know, what your goals are. You know, they say in marriages, right? You need to talk about your finances. It's the #1 cause of divorce in the nation. So it's just, what's the reality? The reality is I don't work out enough, and I need to make a goal and stick to it. So that's the main message from this slide. Golly. Sticky computer today. I don't know, guys. I apologize. Let's see if we can get it to advance. I have some good resource pages. See, and now I just flew through them. Our way forward is right here in the middle. That's the one I talked about at the beginning of our program. A lot of great vignettes and tools for talking to your doctor. CancerNet mobile, cancer.net mobile, they have this crazy app to manage your cancer care. And from my little notes, it can generate a health report with data from Apple Health when you opt in. So it's actually something you can print out or show your provider when you go back for your visits. So that's really the one from this screen I would want to share. I apologize. I've mentioned the NOCC and OCRA. So if you Google those are good ones. And if you got a comfort tote from Ashley or Jennifer, or from any of your nurse navigators or social workers, there should be a list of a lot of these resources in there as well. So I apologize. I don't know why we're freezing up here. Foundation for Women's Cancer is another one. Again, these are large national cancer groups. This is not an exhaustive list. So I guess I can take a few minutes, Ashley, if we still have time, to answer any questions anyone has. I hope this was helpful. To those listening today, I wish I could see your faces, but I can't, you know, unless I stop sharing maybe, but again, you don't have to come on screen for, you know, to keep you anonymous here. But any questions in the chat, Ashley?
Nothing yet. That was very, very informative, Susie. Thank you so much.
You are welcome.
If anyone has any chats or any questions, please feel free to put them in the chat. Otherwise, go ahead and you can unmute yourself as well and ask Susie directly.
And if you don't think of them now, you can always give Ashley a call at the office. She knows how to connect with me, and I'd be happy to give her any feedback, and she can get it back to you. So
I'll go ahead and put my email in the chat. Here's one, Susie. What stage is recurrent cancer?
So it's almost like it's its own stage. So we always look at where you were initially, you know, when we're reevaluating your disease at all your follow-up visits. So when we would go into the room with the provider, he would re-ask, you know, or she would re-ask, what stage was she? What was her histology or pathology? Did she have residual disease? So again, all those pieces of the puzzle still play a role when we're looking at our patients' 2 years and 5 years and 7 years later, right? But once you've had your first recurrence, it's new stage, and we say that you're a recurrent ovarian cancer patient. And then from there we say she is platinum sensitive or she's not platinum sensitive. So again, all these things that we can often keep learning about our patients as they go through their journey.
Great. Any other questions? I don't see anything else in the chat quite yet. I did go ahead and put my email in there, so if anything comes up after the session, I'll be more than happy to forward it on to Susie and get an answer back as well.
Yeah, I do have my notes here. So the only other one, Cancer Care is another resource that I didn't mention. I think that was the last one. And then specifically from GSK, if you need support or have additional questions that I didn't address or want to know more about maintenance therapy and what's available, we have a GSK response center, and they have a 1-800 number where you can actually get in contact with a nurse. The number is, I don't know if you want to type it in, Ashley, it's 1-888-825-5249. So they have nurses and pharmacists there that they cannot give medical advice, but they can try and answer questions about GSK medicines and things like that. So
another question that came in, Susie, and we've got a couple minutes. I'm not sure if you'll be able to answer this one particularly, but maybe you might know from GSK, what new drugs are coming along? Do you know anything in particular, or is it still just more kind of PARPs, immunotherapies, that?
Yeah, I know that one of the big things that you may always hear about is combination therapy. So some of these drugs that we have seen benefit from, they often are being studied with another drug that may already have an approval. So, always keep combination therapy in mind as something that might be beneficial. And again, going to some of those national organizations, they'll have good information there that's of value to you versus just doing a wide open Google search, right? And then, you can always get a second opinion is something we would always tell our patients. Even the oncologist, he or she would say, get a second opinion, especially if you're at a cross point where you don't really like the cards that are on the table, or you don't like, option A or B, right? So sometimes it's good to make sure, you may have all the trust in the world in your doctor, but sometimes it's good to hear it from a new or different doctor at any stage in the game. And that's all that it is a second opinion. You can come back to your surgeon or your oncologist, but oftentimes maybe going even to another healthcare system in another city. We would sometimes send people to UW-Madison. And they may be more research-based, right? Or they may have research studies that we didn't have where I practiced, right? Or if people would go to Chicago or they go to Mayo. So there's always a role for that. It doesn't always have to be at end stage, right? There is sometimes value in just knowing that you are doing the right thing and you're right on the right track, and you're in this other gynec or this oncologist agrees with what your doctor is doing. So that would be really the main thing that I would add as far as new advances is just keep asking questions, find out who the players are at your cancer center, and just keep reading and looking and then living your life, right? I mean, we can't make this our whole world, right? We have families and loved ones and things that we enjoy. So keep doing the things you enjoy, and there is hope. So it was clairvoyant at the survivors brunch this weekend. I mean, more than half the folks, if not 3/4 that came to my table were 10-year survivors plus, right? So just know that this is not the end, okay? And to hang in there, and this day too shall pass, right? The hard days, the beginning, and the bumps along the way. So thank you everyone for listening today and letting me share what I've learned over the last 15 years in GYN oncology care.
Thank you so much, Susie. I will add one point before we go here. Susie did mention OCRA. They have a great website where they can help you match with clinical trials. So that would be a great way for finding out about new drugs that are coming out, combination of drugs, things that you can get in, and all different institutes have different clinical trials. So it's important to maybe go to a broader site like that can help match and go from there. So just wanted to put that out there. OCRA and then clarity.com. Both of those are good clinical trial matches.
And you can take them right back to your nurse or doctor and say, I read about this. What do you know about it? So don't ever worry about offending them. They're in this fight with you, or they should be, right? So you just keep, I mean, I can't tell you, for years, maybe 4 years, people would be bringing me articles on PARP inhibitors, and I'd be pulling my hair out going, I don't know. There's nothing out yet, right? So there's always this long period before something gets approval, because they have to make sure it's safe for the patient and studied enough. So keep fighting.
Great. Thank you all so much. Great. This was fantastic, Susie. Thank you again for joining us. And I hope everyone has a great day.
Yes. Thank you so much, everyone, for taking the time.
Bye.
Bye-bye.